everyone. I'm Mona, and today we are talking with Nadine Evans, author of Mastering the Monthly Madness: How Therapy Helps Ease the Mayhem of PMDD. Nadine is a registered psychotherapist and the founder of In-Part Therapy, a practice dedicated to supporting individuals through life transitions, mental health challenges, and hormonal health-related conditions. Nadine, thank you so much for being with us today.
Thank you for having me.
While I was reading your book, I was really super fascinated about your journey. Your journey with PMDD didn't actually started right after the diagnosis, right? Can you share the story with us?
Yeah. So I was diagnosed 10 years ago. And
Uh-huh.
what was really interesting is I had no idea what PMDD was. I had never heard it before. And I had gone to the doctor really just for, I think I needed some blood tests or something like that. And my doctor at the time was on vacation. And this was an older gentleman who was probably in his mid 60s who had been seeing me for years. And I wasn't super comfortable talking about mental health with him.
Mm-hmm.
So he was on vacation, and there was a younger doctor taking his place, and it was a female, and she was just lovely. And I don't know if it was because of her age or just that she was new or for whatever reason, she spent a lot of time asking me questions, and I really opened up to her. And I started
Mm-hmm.
talking about how, sometimes I just felt so angry when I was driving in my car that I could literally kill somebody. I didn't care about the implications. I didn't care about anybody, only how angry I was. Or I told her, a few days before I had been feeling so sad that I felt like I was in this pit of despair and there was no point for anything. And she kept
Mm-hmm.
asking questions and that kind of thing. And eventually, she gave me a prescription for an antidepressant and gave me a referral to a gynecologist. So I did not take the antidepressants because I thought to myself, well, I don't need antidepressants. Goodness, I'm fine. It's only like a few, maybe 5 or 6 days of the month where I feel bad and I'm good. So I had to wait about 6 months before I saw the specialist. And when I saw the person, she told me, she's like, so you have PMDD. And I was unfamiliar with that term. And I thought, I have what now? She said, but it's okay because you've been taking the antidepressants. And I said, oh, no, I haven't been taking antidepressants. I haven't been doing anything. So they explained it a little bit to me, what PMDD was. And then they gave me another prescription. And then they gave me birth control pills. And because of the stigma with antidepressants at the time, I didn't dare take antidepressants. I was thinking, oh my goodness, I wouldn't need those. But I did take the birth control pills and I found them to be helpful-ish. They certainly took away some of it. And the way my PMDD kind of manifested was about probably 3 or 4 times a year, I would just go into a blind rage. Or usually in the winter months, I would get really, really depressed, really sad, but only for a few days. And then once I got my period, I was fine. So I just kind of endured it. I just thought, oh, this is what I have. It's a thing. I did very little research. In fact, none as to what PMDD meant. I
Mm-hmm.
knew it was on something called the DSM-5. I didn't know what the DSM-5 was. All I knew was it was a thing for psychiatric care. So I didn't really talk about it. I didn't really mention it until about 4 years later when I had a incident so bad that I was planning my suicide. And that was a really, really tough one. And at that point, I was like, okay, it's time. It's time to be honest. It's time to learn about this thing. It's time to be upfront with the people that I love. So at that point, I went to my doctor and she really encouraged me. She was like, for some reason, you believe that you have to endure this thing, that, you just have it, you have to deal with it. But she's like, medication exists to help. And she's like, you haven't even tried the basic level of medication. And so she prescribed me sertraline. And when I started taking that medication, my whole brain just opened up. I was like, wow, that really, really helped. She also encouraged CBT for therapy and a number of different things. And that was really about 4 years into my diagnosis. And things have been very, very different since. I have taken control of my PMDD, learned a lot, changed careers, all that kind of stuff. And yeah, I am very much a PMDD advocate today.
Wow. And yeah, let's talk about this career transitioning, because it was not just a matter of accepting and dealing and managing your PMDD. You also made that like a whole life-changing experience. How
I
was that?
did. I did. I was so one of the things I like to talk about in with my clients and with my our group program is listening to your luteal self. And I was somebody who was actually quite unhappy in my career. And every time I would hit my luteal phase, which of course, for the listeners, in case they're unaware, luteal phase is the time between ovulation and the start of our period. That's when PMDDers get really, really have noticeable mental health and physical health changes. So when we're in our luteal phase, we really kind of need to listen to ourselves. And month after month after month after month, I was wanting to quit my job. I was just like, and I wanted to, go out in a blaze of glory, yell and scream and fight. And I would have dreams sometimes that was me quitting and all that. But that wasn't very feasible for me. But I guess what I was feeling was very unhappy in my job. And I worked in the corporate world for 25 years. I was in the corporate world, and I finished my career actually as a vice president of marketing. So I had a very lucrative, successful
Mm-hmm.
career in that way, but I just was fundamentally unhappy. I was always interested in psychology as just a topic, but I never saw myself being in this world until after I began medication and began my journey into wellness. And I found a master's program and then started to do a lot of investigation into PMDD. And when I began the master's program, everything I studied in my master's was regarding PMDD. And then I really started to visualize a career in this, to be like, wow, I really want to help people. I really want to focus my attention. So when I graduated, I launched Impart Therapy, and we're primarily focused on PMDD, helping people with PMDD. So that's what led me here. It was a little bit very selfish in many ways on my part because I was unhappy in my career and I love what I'm doing now, but also just this kind of curiosity and passion to be, hey, this thing is really interesting and not enough people know about it. And we know that there's help out there and I really want to help. And yeah, so here I am.
This is so inspiring. It's beautiful, Nadine.
Yeah, thank you.
And how was this realization? So first we have PMDD diagnosis, we have PMDD management, the whole career transitioning, and then we have the book.
Mm-hmm.
In which moment did you realize, okay, now I have my personal experience, my new experience as a psychotherapist, and now it's time for me to write this book?
So first, what I did was developed a group program, and
Hmm.
I put together a 6-week group program for PMDD sufferers that was primarily about DBT, dialectical behavioral therapy. So from there, the book came about. So this was just a few months after my graduating from the master's program that I did this program. And then I realized I'm like, I have kind of the bones of it, the structure essentially. And what I should do is turn it into a book, and which is really a helpful book. Now, at the time, I was, trying to find as much as I could about PMDD out there. Anything that anybody who wrote a book at all, I was collecting and reading and trying to see how resourceful it could be. And there were some really good ones. And there was a couple of really bad ones. One I don't even understand. I think it was written by AI or a computer somewhere. It was just, oh my goodness, so terrible. And I thought there isn't really anything out there that actually looks at PMDD from a therapy perspective. So
Hmm.
obviously we look at PMDD from hormonal, medication, all that kind of stuff. But, can we look at something that takes some of the fundamental kind of things about of therapy, like DBT, dialectical behavioral therapy, and turn it into a workbook? So that's where that came about. And it took me roughly about a year to go from idea conception to actually, I would say probably a bit longer because the editing process took a little longer than I would have liked. But it was, yeah, I'd say probably actually, now that I say that, about a year and a half from the time idea conception to final book.
And the book reception, how has been so far?
Yeah, it's been really great. I've been very, very happy with it. It is a small book. It's not meant to be a blockbuster. I kind of tease my friends, it's a book about premenstrual dysphoric disorder and dialectical behavioral therapy. So I'm going to sell 1 billion copies. It is a very, very niche book, of course, but I've been very happy with the reception of it and what I'm seeing now of people purchasing it all over the world, which has been really, really exciting. When I first published, I sent it to my clients, and my clients really enjoyed it. We use that as our sort of our basis for our individual therapy. And some clients are really, really glowing about it, and then some clients say, "Well, I'm really I like it because it's short." It kind of depends, but I've been really, really happy with the reception.
Awesome. Um, we know that PMDD still is widely misunderstood, right?
Mhm.
And what do you think that are the biggest misconceptions about this condition that we still need to be more aware and more focused on addressing?
Over time, women have been told, either, culturally or just their own sort of, medical practitioners telling us that this is normal, that, what, oh, it's just a woman thing. I hear that constantly. I'm from a very small town where I grew up in a family where I have no sisters, just brothers. And it's a very male dominated environment. And anytime you mention any of this, it's like, oh, that's just woman stuff. Oh, so we over time have been taught to minimize this condition. And of course, there's a cultural element too. Different cultures deal with this very, very differently. So it is remarkably difficult to get to advocate for this condition, in that, it is a thing. It is a very, very real condition that is very damaging. And, like I say to clients, suicidal ideation is a very common part of PMDD. You could feel fantastic on a Wednesday and suicidal by Thursday. And because of the abrupt and acute nature of this, it puts us more at risk for impulsive kind of things. So it is a very, very important mental health issue to pay attention to, but it is minimized, like women's
Yeah.
health. And I am a almost 49-year-old woman who's well into perimenopause, and I'm seeing firsthand now just how much these conditions are minimized. So it's a global challenge, and the more that women can understand this and realize, when you're feeling suicidal because it is late in your luteal phase, and you're going to get your period, and 2 days later you'll feel fine. This is not a normal or typical kind of reaction to your period. Something else is wrong here, and we need to understand it and know that there's help available. We don't have to just endure this condition. We can do the things that need to be done to feel better.
Yeah, absolutely. Yeah. Just one personal comment while I was listening to you. I have to say this. I don't have PMDD, but I do have endometriosis, and I'm about
Ah.
to turn 40 years old. But I was just recently diagnosed. And because, like, my whole life, what I heard was like, oh, this pain is normal. This is a women thing, like always this gaslighting medical type of behavior. And it was just after I started working at Bell that I understood, oh, my personal void, it's actually a gender gap. There's a lot of there's a lot of things that are not being addressed, that are putting aside, and what I'm feeling is not normal. And there's help available. And it was life changing for me. And I think, like, what I like most about doing these interviews and doing this work is finally putting, like, female health, like, in general, in the center of the debate, like the chance that we have now to openly talk about these conditions, and, like, to actually push forward, like, better conditions for us.
That share, because endometriosis is so difficult to diagnose, and women have had it for years and years and years, and just kind of, again, endured the pain, said it end up in the emergency room for menstrual pain. This is not okay. We need to be able to diagnose and provide care. There's a link. There seems to be a link between endo and PCOS and PMDD. There's links that we're seeing more and more for that kind of thing. So really what we do need is women to understand, or menstruators to understand, that they have this, and, medical care professionals to pay more attention to it, because so much of what we go through is not typical and we need help.
Yeah. You talked about suicide, and this hurts me so badly, because we are now kind of understanding how complex, how dangerous, and how multifaceted is this condition, and how it goes like in your whole life, like it takes everything. And yeah, we seriously need some change in this area.
We do. We need to normalize. And it is very much that. It's surprising to see, when we think about suicide ideation, how common it is with PMDD. I had a PMDD client mention to me the other day, she works with vulnerable populations like homeless people. And she said, it's shocking to think about the homeless people that she comes in contact with, that, generally they're miserable. They have, sickness, mental health issues, covered in bugs sometimes. And she's like, and they're not suicidal. They're not. And here's her, a PMDD sufferer, who is helping them, who feels the suicide ideation on, a regular basis. And again, we think it's we don't put enough emphasis on how important it is to pay attention to that as a symptom. Many therapists think, oh, if somebody's suicidal, it's like, oh my goodness, we have to call 911, we have to get them in the hospital. But with PMDD, it's kind of different in that it's like, you feel suicide, and if we're lucky, we won't act on it. We will just, there's no plans. There's just the thought of, oh, I wish I could push a button. I'm worthless. I'm terrible. I'm, all of these kind of negative thoughts. But then we know, part of us knows that if we hold on just a few days or a week, it's going to go away and we're going to feel fantastic again. So, all of that to say, it is interesting to look at the suicidal ideation kind of side of things, and how common that is as a PMDD symptom, and just how necessary it is to kind of, normalize that as a symptom and talk about it, because some people feel that talking about suicide makes us go out and do it. In the end, the opposite is true.
It's the opposite. Yeah, absolutely. And what do you think are the biggest challenges that people face when seeking treatment?
A lot of folks prefer to have a diagnosis, and diagnoses can be quite easy if you have a doctor open to that, but also quite difficult. So I have some clients who have gone to doctors who have said, oh, that's not even a thing. PMDD doesn't exist. We have some people in the world that believe PMS isn't even a thing. So that's difficult. But I will say, I've noticed a trend in the last 5 years, huge differences in what I'm seeing from young people, because I'm seeing a lot more young people getting diagnosed with this condition, which is really quite exciting. And I say that in a tongue-in-cheek kind of way, because when I have a 19-year-old coming to me who's been diagnosed with PMDD, I'm very grateful to medical professionals who have diagnosed that person with PMDD, because they have a long road ahead of them, but they're going to learn how to deal with it at 19. So by the time they're 44 and full in the depths of perimenopause, they're going to have a well understanding and a good control of their PMDD symptoms. So I would say the biggest challenge for getting diagnosed, the biggest challenge is getting diagnosed. It is something that some medical professionals are very open to. Some doctors are still very much like, oh, Dr. Google, look at you, you're coming in, So it really, the defensiveness we see sometimes in the medical field can be challenging. However, I'm seeing that change. I'm seeing that shift a lot more. So if menstruators feel that they need the diagnosis, and some don't, some are very, very comfortable to be like, okay, I don't officially have this, but I know I have it. And from a therapy perspective, we don't need an official diagnosis to treat as if one does have PMDD. But some people do want to have the official diagnosis, in which case it's very good to go into their medical practitioner with evidence, and we ask that they track their cycle for 3 months. Really kind of go through everything. The more information they have for the doctor, the better. And I've a lot more of my clients are coming in and they say, I went to my doctor and I had all this information and the doctor said, yep, sounds like you got it. Okay, which is so wonderful to hear, because that definitely wasn't the case even, 6-7 years ago. So we're seeing that shift, which is really nice.
And you were talking about DBT, CBT. I want to talk about this approaches, all this landscape, and this. First of all, understanding this connection between mental health and hormonal health, and how those therapeutic approaches that you incorporate, DBT, CBT, ACT, EMDR, right?
All of the acronyms. Yeah, all of those acronyms. So I apologize in advance. I'm a giant nerd. This is what I tell my clients. I love to talk about the theory behind this stuff, but I'll kind of just a little bit. So most people have heard of CBT, cognitive behavioral therapy. It is a beautiful, wonderful type of therapy that has so much evidence-based, cases and research behind it. CBT can be effective for PMDD. And there has been studies that have shown that it is effective. CBT tracks kind of the thoughts, behaviors, emotions, and really kind of does a link. But CBT really relies on logic. It's kind of like, engaging the prefrontal cortex and again, this is where I'm really nerdy, so apologies. But yeah, it's really kind of getting the blood flowing to the brain so we can be logical and understand things from a rational perspective, which can be remarkably difficult for PMDDers in the depth of our luteal. Because a lot of times we feel things with the body and we're having a reaction, but we can't necessarily, tap into the brain in many ways. I'm oversimplifying by a lot here, so apologies to anybody out here who is a DBT and CBT expert, but I'm definitely oversimplifying. But essentially we feel things. We're like, we're having these emotions and we don't, it's very hard to be like, okay, stop, examine the evidence. How do I, that kind of thing. So for that reason, some of the third generational behavioral therapies, such as DBT and ACT, tend to be a little more preferable. And what those types of therapies really tap into is more of the mind-body connection. Now, my preferred, even though I do touch on ACT, I'm more of a DBT person. So dialectical behavioral therapy is really about kind of understanding to say, okay, it's about the mind and the body, and how can we sort of, interpret what's going on in a way that we can use. So DBT has 4 pillars: emotional regulation, distress tolerance, mindfulness, and interpersonal effectiveness. And it was developed for borderline personality disorder. And that type of borderline personality disorder, in many ways, PMDD can be very similar to that. When we're having an issue in our luteal, a lot of practitioners may confuse how we act with borderline personality disorder. And for that reason, DBT is an excellent type of therapy. So that generally is my preferred therapy of choice when I am dealing with PMDD folks. Now, EMDR is a trauma-based therapy. I am certified in EMDR. EMDR is not something that I would start with PMDD. EMDR is eye movement desensitization and reprocessing, and it involves kind of using the brain from a bilateral kind of perspective to look at memories. I know I'm kind of like really geeking out here. So again, to really kind of go back and look at memories and kind of understand them differently, let's say. So, sorry.
So it's kind of, it is focused on trauma, basically.
Yes.
So
it can be used for anxiety. Yeah.
Revisiting and then rewriting the story from a different perspective. Something
that
like
is
that.
Exactly it. Yep. Yeah. And it's essentially, we wouldn't use EMDR unless there's trauma with PMDD. And that can be quite helpful. We don't start with EMDR, but we get to EMDR if need be. So probably not surprisingly, some PMDD folks have quite a bit of trauma in their background. There might be sexual abuse, physical abuse, emotional abuse, like any therapy client that comes to me. So what we like to do is treat the PMDD first, kind of start in the present, and then when ready, we can go back to the past. And that's what we could use EMDR for as a tool. But EMDR is only a secondary type of therapy, if that makes sense. So DBT, CBT, and ACT are skills-based, which means we learn tools to be like, okay, I'm having some feelings here. Well, rather than just kind of lose my mind at my partner, I'm going to try to understand, to say, hey, I'm in my luteal phase. I am feeling this way. I have some feelings. I'm going to process them, and then I'm going to react, rather than kind of a lot of times during those periods, we have an emotion and then we react, and that can be very, very problematic for our interpersonal relationships. So that's what these, that's why those kind of therapies work very well, because they're tool-based. They give us kind of a structure to help.
Mm-hmm. I understand. And in your book, you talk about 4 key steps for the symptom management.
The 4 steps, really what we start with so PMDD is kind of all encompassing, and there's different steps that I look at. So the first step is psychoeducation. So a lot of times clients will come in and they've just found out they have PMDD. They know it's an issue, but they haven't really done the things that they need to understand what PMDD is and how it shows up for them. And I put myself in that category. For the first 4 to 5 years of my own diagnosis, I had no idea what PMDD meant or what my triggers were, all that. So that's what we do first. And then what we want to make sure is that every PMDD person has medical intervention. There needs to be a doctor, a nurse practitioner, someone involved here that's looking at things like medication. I always like naturopaths. Naturopaths can be very, very effective with things like vitamins. All of that counts. And sometimes birth control, different types of birth control can be very effective. So that's that medical intervention. That's step 2. Step 3 is understanding your vulnerabilities. And we look at things like emotional, physical, mental vulnerabilities. Stress is a big one. I want to know what the person does for a living, how they are managing stress. Most PMDDers, as you can imagine, have a massive amount of stress. We see certain types of careers more likely to, I see certain types of careers that are more stressful, is what I'm trying to say there. Sleep is a big one. Anytime that we've had any kind of sickness, any kind of health issues, like you'd mentioned endo, PCOS, any of that stuff, we want to kind of look at all of that. So that's where we see those vulnerabilities. And the 4th step is the actual therapy itself. So that's all the stuff that I just talked about. That's where we do in terms of a therapy. Now, therapy isn't just skill building. It's also self-compassion, self-kindness, boundaries, all the stuff that need to happen there. And that's kind of where we see a lot of it. A lot of the growth there in terms of the therapy side of things. But PMDD management, from what I do, it's those 4 things. I have it a circle, because when I show my clients, it's kind of in a circle. Step 1, step 2, step 3, step 4. Yeah.
Awesome. Let's talk about your PMDD support group as well. I saw that you have a group and also a support group for partners or for couples, actually, right?
So the couples is a new thing that I've launched, which is not a group, but it's individual support for couples, which we're seeing a huge need for as time goes on. So I do short-term based therapy for couples, and I'm very upfront to say this is not meant to be couples counseling or marriage counseling, but it's more how to deal with PMDD from a couples communication type perspective. For my Zoom group, I'm very pleased about this because we run it once a month. So I used to do, as I mentioned in my book, the genesis of my book came from a group program I did, and this was a 6-week course. The problem with that program was not so much the information, but it was kind of the structure, because people can't necessarily dedicate time to come to this, every week. And I was getting people to say, oh, I can come for 4 of the 6, but and that was a little bit kind of difficult. So what we did is we opened it up. We said, let's just do a support group that's a drop-in. You don't have to register for it. You don't have to pay for it. You just come once a month, and we have different topics. So it's completely free. And people just sit in, and we use DBT. It's like a skill building kind of a thing. And every month there'll be a different topic, and people can share. People can choose to share as much as they want or as little as they want. So we have some people coming who keep their cameras off and they're just listening. And we have a number of people who come, keep their cameras on, and love to share. And it's really interesting because it's been going for almost a year now, and it's been really, really good. And I have my student therapists get to come and help and learn and be a part of this community as well. So the goal for our Zoom group is really just to build a community, to build support and advocate and, teach. So it's been wonderful. And it's most of the people that we have coming are in Canada, but it's welcome to anybody. Anybody anywhere in the world can come to this session. It is just that it's Eastern Standard Time, so that can be a little problematic for anybody who might be in Australia who wants to come. But everybody's welcome.
Awesome. And for me, this is such a huge step for PMDD warriors, PMDD patients, because I think it is a condition that one of the major factors that one could feel is the sense of isolation, right? The sense of, because usually when you deal with such a hard symptoms, that you tend to isolate, right? You tend to try to silence yourself and don't, and in a kind of way of avoiding to spread your symptoms away. So you isolate yourself. So when you have the opportunity to be with another people who also share the same struggles, it's such a big part on this journey,
It very much is. And it's interesting, as you mentioned, isolation, because you're right. When we have any type of condition, whether, it be depression, anxiety, we're seeing it a lot with grief, which of course is not a condition, but a situation. A lot of people feel very alone in their pain. And PMDD in particular, we know that it passes. So we could isolate and, spend a week. I've had clients mention they'll go to a hotel to stay away from their family for a few days and just isolate. That can be an effective short-term coping mechanism, but not in the long term. And we want to discourage that because, PMDDers are not alone. And so many people, and this is not unique to PMDD, so many people, the pain gets so bad that they think it's better off to simply die by suicide than admit they have a problem. And that is, I just saw your face there. That is pretty heavy. That is absolutely true. And this is so very, very wrong. What we want to do is say, you are not alone. Let's just talk about it. Let's talk about someone like me, a middle class, a woman who is an executive. I'm married, children, all that kind of stuff. And I still, on that day, was planning my suicide. I still felt I could not ask for help. It was better for me to go away and die. And when we have people in the world feeling that way, that needs to change. So what we need to do is create this environment where people can talk. And sometimes not everybody is ready to talk. Sometimes we want to listen, and that's okay, because even just being in an environment where somebody else is saying how you feel just lifts that feeling of alone. It's almost like that fog clearing. It's like, oh, wow, others are like me. Others feel the same. So that's really what we love about the Zoom group.
You also mentioned advocacy, and I think it's a big part of your work, right? So what steps do you think individuals can take to advocate for themselves in the medical settings?
Really just be equipped with information. So tracking their cycle, coming to their doctor, knowing about it. And we have to say, and I was actually just reading an article. This is not my own. I just heard this recently, but I'll mention this. And I don't have a source, so if whoever said this is listening to this, please forgive me. But basically, it's putting things in a language that doctors can understand. So for PMDD, we don't just want to say, oh yeah, my periods are really, or my PMS is really bad. We want to say it's interfering with my quality of life. It is interfering with my ability to go to work. It is causing, massive stress on my partnership, on my relationship. But, so being able to put things in that kind of language is very helpful for doctors. So, mental health issues, particularly PMDD, it has to, there's a criteria, and it can't just be, hey, I was really sad, so, I cried. It's better to be said, hey, I was so sad that I couldn't get out of bed and I cried all day and I missed work, or I had to call into work sick again and I'm calling into work, twice a month, every month. That is kind of quantifiable information that doctors can use. So really that advocacy comes down to giving the doctors the right information so that doctors can then help. And the more that clients can go to their medical professionals and say that, the more helpful it will be. And like I said, we're seeing a change. I've had clients, for example, go into their doctor. It's like, oh, you're PMS. Well, it's not PMS. It's PMDD. It's something much more serious. We don't want it undermined. We need to use the right terms for it. We need to make space for it. And the more the medical community can get on board with that, the better. And like I said, I'm seeing a huge change, which is really, really nice. And that's the advocacy. I have clients, for example, who are doctors themselves. And that's so helpful because I think, oh my God, thank goodness that you as a doctor and have this. And now just think about all of the folks that you're going to be able to help because you know of this and you know what to do with this and you're seeking help. So it's really been wonderful in terms of advocacy. And the more that we can talk about it, the more that people like you, like Bell Health, doing what they do to put the message out there. It's kind of communication on a mass scale, helping so many menstruating people with this, which is it's really wonderful.
Yeah. Yeah. As you just said, like a lot has been changing, thankfully. And but it's still like looking ahead, like what changes would you like to see in how PMDD is addressed in healthcare and society that are still not there?
One of the bigger things we're going to see, hopefully in the future, is more space on an insurance side from a disability perspective. PMDD in most places is not recognized as a disability. And PMDD exists on a continuum, like like pretty much every type of medical or mental health issue. It is, it ranges from mild to, severe. So if PMDD were recognized from a disability, those with severe PMDD who need time to not work and to recover, it would be wonderful if insurance companies and the insurance world in general could see that. And I think that's where we're going. Certainly in Canada, we've seen a few cases here and there of people receiving disability benefits, and globally, it would be interesting to see how that's increasing over time. More funding, I think, for those who are lower income for PMDD treatment. In Canada, we have universal healthcare, so everybody does have access to, in theory, to a doctor for help for this kind of stuff. But what we just need is more and more information, more advocacy to help with that kind of stuff. So, there are times in a PMDD person's life where they won't be able to work because it gets it can get very serious. It isn't because of the type of nature of PMDD, because it's cyclical. It isn't going to be all the time. And, the more employers can understand and be there and be helpful for this kind of stuff. So really, it's just kind of a mass understanding of what those who have PMDD need and how we can make it a little more accessible. A lot more employers are allowing, their employees to work from home, which is great. That's not unique to PMDD, but the more that we can do that kind of stuff, because, if you have PMDD, you could still work. You just might not be able to go into an office where there's massive stress and lots of interactions. So we might not be feeling up to it. That doesn't mean we still can't work. So really kind of, lots of different groups coming together to help the PMDDer, be able to live their life in an effective way.
Nadine, we are getting to the end of our interview. I would like to ask if there's something that I didn't ask that you would like to share, to discuss, like anything, or maybe share some thoughts with your current readers or future readers, whatever. The mic is yours.
Thank you. Feels like a lot of power. This is great. Thank you. No, I was going to say thank you so much. But I think the biggest thing that I want to highlight for PMDDers, and first I want to say one of the things that I sometimes say is the term women, which of course menstruators are not, it's not unique to women. So I apologize. I do mean to be gender inclusive. And I try to use the language PMDD folks or just menstruators in general. So I apologize if I have not been as inclusive during this session as I would have liked. The other thing I would want to say is there's certain times in a PMDD person's life that are going to be remarkably difficult for them. We want to look out for that. So obviously puberty is when that kind of can emerge for some people. Some people, the minute they get their first period, we're seeing PMDD emerge. That may or may not happen. Pregnancy is an interesting time because, during the pregnancy, typically we see PMDD symptoms go away, but they can emerge, much worse once the cycle comes back. So it's those times we want to be really a PMDDer to kind of understand. And they can be at risk for things like postpartum depression, that kind of thing. So we want to, the more that the PMDDer can understand, hey, it's possible that I could be at risk for these kinds of things. That's why it's so great to have a 19-year-old being like, hey, I've got this. Now I need to pay attention to it for the rest of my life. The next most important time frame in a menstruator's life is perimenopause. And I mentioned that word because this is something I'm going through. Perimenopause is a particularly difficult time for PMDDers because of the fluctuations of hormones. And perimenopause can last a decade or even longer. So it is really important for PMDDers to pay attention to that, because a lot of times what we're seeing is, people who didn't realize they have PMDD, and then, perimenopause tends to emerge the early stages, and then it's like, oh, I also have this thing. So it's important to kind of know what I've heard somebody mention it, the 3 Ps. Puberty, pregnancy, and perimenopause as part of kind of the PMDD lens. We look at it, it's meant to be sort of from a full health perspective from women's health that doesn't necessarily be unique to PMDD. But if you do have PMDD, please pay attention to those 3 areas of your life. If you have PMDD and you have a teenage daughter, there is a genetic link. So she may develop PMDD, she or they may develop PMDD. So all we want to do is kind of notice and be like, hey, I could have this thing, or you could have this thing. And we just want to just talk about it. The more we talk about it, the better it will be.
Yeah, absolutely. Oh, Nadine, thank you so much for this wonderful conversation.
Yeah, thank
Thank
you
you
for
for your
having
work.
me. Thank you so much. And thank you for you and Bell Health and what you guys do. We really appreciate all that you're doing for women's health. So thank you.
Thank you. And thank you all for listening, watching this. I just want to also remind you to download the Bell app that was built to help you to be your daily companion on tracking and managing your symptoms with science-based tools. Thank you so much for watching, and until next time. Bye. Bye, Nadine.